Top Med Talk.
Monty Mython here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on Top Med Talk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
Mudge here, welcome to Top Med Talk. This piece is taken from the 8th Australian and New Zealand Symposium of Perioperative Medicine Special Interest Group. Updates in Perioperative Medicine 360, which took place between November the 7th and the 9th of 2019. This piece is presented by Professor Alison Mudge, Conjoint Professor of Medicine at the Royal Brisbane Clinical Unit Faculty of Medicine, and Gideon Caplan, Associate Professor of Geriatrics at the Prince of Wales Hospital in Sydney. This is part one of a two-part piece.
Okay, we might make a start. We're very excited to have such a full room come to hear about delirium. Any of you who heard me talk yesterday know that this is an absolute passion of mine and also of my co-speaker Gideon Caplan, who will introduce himself for the second half of the talk this morning. So we're going to be talking about delirium. My background is that I'm a general physician by background, but I'm a health services researcher, and I'm very interested in how we try to change our models of care to improve outcomes in older hospital patients. And I think nowhere is the evidence so clear for that as in preventing delirium, both in medical and in surgical patients. So that's a real passion of mine. But we're going to talk specifically about the brain and the older surgical patient today. So what we're going to try and cover between the two of us is what delirium is, a little bit about its epidemiology and why it's a problem, why it's bad. We're going to talk a little bit about who might be at risk and how we think about risk. I'm going to be particularly talking about prevention because that's my big passion. And then Gideon's going to be talking a lot more about the pathophysiology of this still really quite mysterious condition, and a little bit about what treatment options are currently and into the future. So that's kind of the shape of the talk this morning. So let's talk about delirium. So one of the really tricky things about delirium is that the diagnosis is still defined in the DSM-5, right? So in the psychiatric diagnoses. And I think that this has been why physicians and anaesthetists and surgeons and other groups have been really slow to engage around delirium because it actually still has all the stigma of mental illness. And I think that a really useful way to think about delirium is to just think about it as acute brain failure. And it's as serious and important as failure of any other organ. In fact, the evidence is for that from people's choice point of view, brain failure is far more feared and something people are far more worried about than really other organ failures. So acute brain failure is really the concept that we're talking about. And there are obviously some specific diagnostic criteria, and the new DSM-5 criteria particularly emphasise acute impairment in attention. From my point of view as a physician, when I see impaired attention is when the junior medical staff say someone's a poor historian. That often means poor attention. So inattention and cognitive impairment that's acute in onset and fluctuating and due to a medical condition or drug. And of course, in the case of post-operative delirium, this is really occurring in the context of an operation. And I think that there are these parallel literatures about delirium and about post-operative delirium, and again, they've often been conceptualised as different things. There's been a lot of different terminology used, and I think it's been very helpful in the recent past that there's been some better harmonisation of the language. And I think Aisling, if you were in the talk earlier this morning, talked a little bit about post-operative cognitive dysfunction. There is a new statement from a consensus organisation that's really starting to harmonise the language around what happens with brains after surgery. And so there's been confusing terminology around emergence delirium, post-operative cognitive dysfunction, which is actually defined as a measurement thing rather than a clinical thing. And there is now more harmonisation with the current DSM-5 definitions and really talking about, well, post-operative delirium is what happens not in the immediate couple of hours after surgery, but a period of lucidity and then occurrence of delirium in the first 7 days is now clearly the definition of what we can call post-operative delirium. And then there's this clear syndrome of people not being themselves a month or 3 months or 6 months down the track that probably is much more akin to chronic brain failure or dementia rather than acute failure or delirium. And in an individual, it might be a little bit hard to know whether this is prolonged delirium or whether this is actually established and unchanging cognitive impairment during that kind of interim period between sort of 7 days and the first month or so. But these, I think it's going to be very helpful in the literature that we're going to see much more harmonised terminology, and it's going to make it much more easy for us to understand pathophysiology and the impact of interventions. So that's a very useful reference that's quite recent. So I'm not going to be talking about the other post-operative neurocognitive syndromes. I'm going to be talking just about delirium. And I think that this is a very useful way to think about delirium. So Sharon Anui is really one of the great pioneers in the world around delirium and pioneered the first delirium prevention program and did a lot of the early work around the clinical predecessors of delirium. And she really has this lovely, simple model of that delirium is really a relationship between your vulnerability, the vulnerability of your brain, and the size of the insult. So for any of us in the room, if we were to have a major trauma or a very prolonged major, lots of tissue damage operation and end up in the intensive care unit, almost all of us would suffer delirium in that context. And that's increasingly recognised now that we use less sedation in ICU, then it's much more apparent that people are experiencing delirium because we can actually measure for it. Whereas if one of our elderly relatives were to have a relatively minor insult, a urinary tract infection, or a similar kind of minor physiological insult, they might also be at risk of developing severe delirium because they have greater vulnerability, pre-existing vulnerability of the brain. So when we're thinking about risk factors and precipitating factors, that can be a really helpful kind of model. So in terms of risk factors for surgical delirium, they're actually quite similar to risk factors for delirium in anybody. The overwhelming ones are age and cognitive impairment. So delirium increases pretty steeply after the age of 60. But really over the age of 60 you're probably at high risk regardless of how much over that age you are, and the presence of pre-existing cognitive impairment. And this is really one of the great problems in post-surgical patients because we're still really bad at testing people's cognitive function before they go into an operation. And there's now, with good prospective screening, there's increasing evidence that many of our older patient cohorts who are having surgery, particularly vascular surgery and cardiac surgery where there's higher rates of vascular-related cognitive impairment before surgery, that those rates of impairment are really very high. So perhaps 60% or more of our patients going into surgery have undetected cognitive impairment that's going to put them at significant risk of delirium post-operatively. So recognising that risk is really important. Functional impairment, we're also quite poor at measuring, and there's been quite a lot of discussion already in sessions at this conference about how important it is thinking about functional impairment and how some of our frailty measures like the CFS are really good functional measures. So thinking about that functional level before operation. And then sensory impairment, so the patient who comes in with spectacles and a hearing aid is going to be at more risk of developing delirium, and whether that's partly around increasing susceptibility to misperceptions that feed into the hallucination features of that are very common in delirium, or whether it's a marker of greater frailty or other facets is still a little bit unclear, but it's clearly a risk factor. And then previous alcohol intake, particularly for post-operative delirium, has been shown in a number of studies to be important. So you can see that these are not the kind of things that have traditionally been part of our risk assessments in surgical patients, which have focused much more on our likelihood for other acute organ failures. So we're much more interested in cardiorespiratory and renal function, for example. And we really, if we're serious about thinking about post-operative delirium risk, then our pre-operative assessments really need to start incorporating these very, very important predictors. And I'll show you why it's important to think about delirium in a moment. So in terms of the insult, clearly the surgical insult is a really overriding consideration, but we'll talk about some other things we need to think about in a moment. And in terms of the surgical insult, it's very clear that more major operations, so cardiothoracic surgery, major vascular surgery have particularly high rates of delirium. Emergency surgery has higher rates than elective surgery. Prolonged surgery and large amounts of tissue damage certainly seem to be associated with higher rates. And I think just thinking about the surgical procedure, it's important in terms of predicting people who are at risk, but it's probably the least modifiable, and I'll be talking about some of the other things that we might modify, because obviously surgery is not just about the operation, but about the anaesthetic that they receive. It's about the post-operative care that they receive on the ward, and they've become much more areas of interest over the last few years. Okay, so let's think about why delirium is important. So this is some data from a very nice prospective study of elective older surgical patients in the States. And you can see the characteristics in that blue bar, and they looked very carefully using a really well-defined set of criteria. So the Clavien-Dindo accordion classification, complications of grade 2 or above, so that's needing some sort of medical intervention. And they looked very carefully at a whole range of medical complications in these surgical patients, and you can see that when they prospectively elicited delirium outnumbered all other medical complications by a factor of about 3 to 1. All right, so about 8%. All the other organ failures that we think about routinely when we think about post-operative medical complications in surgical patients. But about a quarter of patients experiencing delirium if we actually look. So this is good prospective measurement using a validated tool. So it's very common, and it's much more common in non-elective cohorts than it is in elective cohorts. So this is a sort of a minimum estimate of what delirium prevalence is like in older people. A lot of delirium goes undetected because, as you know, delirium can present either as hyperactive delirium with phenomenology that's related around agitation and sometimes even aggression, and that's the delirium that your junior staff on the wards are being alerted to all the time because that's what's difficult for ward staff to manage. Actually, much more common and associated with poorer outcomes is hypoactive delirium, the sleepy patient, the sort of ISQ continue patient who's just lying meekly in their bed whenever the doctors go round for rounds, and that we don't notice is not eating and drinking and not getting out of bed. And the implications for them are actually more serious. And of course, a lot of patients have mixed phenomenology. So we see a lot of diagnoses missed. If you look at your, I don't know if many of you are familiar with HAC reporting in hospitals. If you're working in theatres, you might not know a lot about HACs apart from the the post-operative complications, but certainly delirium is now a reportable complication, and most hospitals report delirium rates of sort of 1 to 3%, which is a dramatic underrepresentation and really just shows us how much delirium we're missing in routine care. So it's under-recognised and it's really common, and it's got really important implications. So in data from this study, they looked at the outcomes of prolonged length of stay, residential care placement, and readmission, And the blue bar there is people with medical complications only and no delirium. The orange bar is people with delirium only and no complications, and the grey bar is where they had both other medical complications and delirium, which was quite common. And you can see that delirium has very significant impact on outcomes, and it's additive with other medical complications, so it makes things worse regardless of whether you have complications or not. So it's got significant short-term impact on the patient's stay, on the hospital outcomes that we're often measuring, length of stay, readmissions, need for residential care. It has huge impact on patients, and there's now increasing evidence spearheaded by ICU, but we also see in post-surgical patients and medical patients with delirium about significant and lasting distress for patients. And in fact, many patients have lasting distress related to their delirium, and in fact, post-traumatic stress disorder is recognised as a potential consequence of delirium. Patients often have very distressing hallucinations, often involving staff, often very sure that a staff member is trying to harm them or kill them, and even when their delirium resolves, it's very difficult for them to resolve that impression away. So they actually can avoid future healthcare seeking because of fear of going to the hospital, because of this entrenched fear that someone was trying to kill them. And there are some very compelling patient stories now available in the published literature and in video vignettes that are really worth having a look at if you want to know how serious delirium is. And of course, it's very distressing for the staff that look after them, and the nursing staff bear the brunt of this. So the moral distress that's caused to nursing staff by someone who needs nursing cares related to their post-operative recovery but is unable to engage in that care because of their cognitive impairment is very, very distressing for nurses, and I think remains really under-recognised by medical staff. So it's distressing to patients, it's distressing to staff, it's expensive for hospitals, it's got significant implications. And it's common and often unrecognised. So it's a very serious complication. And there's now emerging evidence that it has other long-term consequences, and that episodes of delirium actually make you more likely to get dementia. So again, this is some work from Sharon Anui's group. If you just focus on the bottom slide for the moment, so these are prospectively followed elective surgical patients from the cohort that I showed you earlier, and they are followed, so there's on the y-axis is measures of cognitive impairment. Now the blue cognitive trajectory, so cognitive function measured over time, is for patients who experience delirium in hospital, and the pinkish coloured one is for patients who experience no delirium. So there is often some impairment early in cognitive function that might be related to opiate medications, it might be related to inflammatory effects on the brain. Gideon is going to talk a little bit more about this. But you can see whether in the top figure where they've actually overlaid to adjust for the difference in cognitive impairment between patients who had delirium and didn't, because people who have delirium are more likely to have pre-existing cognitive impairment, that the shape of this trajectory is actually changed. So you get more rapid impairment in cognitive function if you've experienced delirium. And this really supports work that's been done in autopsy studies published last year in JAMA Psychiatry by Daniel Davis's group that is strongly suggestive that the pathological changes that you see in brains in people who have dementia who then develop delirium is much higher than the rate of pathological changes in people who have dementia who didn't have a delirium experience. So there is some interaction between progressive cognitive impairment and delirium that is more than just cognitive impairment being a risk factor for delirium. It actually hastens the progression of dementia, and there are several lines of inquiry coming out about this now. So what does this actually mean in practice? Well, what it means is that delirium is a common complication, and we actually need to be providing realistic consent processes, particularly to our older patients. So age is the most important thing, so anyone over 60. We really need to be talking about delirium as a likely complication. It's much more likely than most of the things that we include in current consent processes. And it has really significant implications in terms of decisions that might need to be made after the first operation. So if you have a vascular patient who you're going to do a partial amputation and there's a good chance that they might need to go back for a definitive procedure. If you're doing a revision of an abdominal procedure and there is a likelihood that that might be a 2-stage procedure, we must recognise that this high prevalence of delirium means that going back and reconsenting the patient later on might well not be viable. So we need to be thinking about that whole post-operative course. We need to be thinking about who might be making decisions on that person's behalf in that period where they're likely to have delirium, because we often just continue to assume consent when that's no longer viable. And we need to be thinking about actually positively looking for delirium in our cases. This is still not a high-level recommendation from expert statements. It's still couched in the terms of consider rescreening, but I think that that's going to change over time, and we're really going to be looking for active screening and monitoring strategies for delirium. In terms of how we might look for delirium, anyone familiar with the 4A's test? So our physicians and geriatricians will be, but I imagine many of the rest of you aren't. So this is a version of the 4A's test that we currently use in our patient risk assessment. So the 4A's test is 4 items. So alertness, orientation, which is 4 simple orientation questions, which looks a bit busy but actually is the stuff any nurse is asking a patient when they go to deliver any cares to them. What's your name? What's your date of birth? Checking identity. An attention question, months of the year backwards. Can you tell me the months of the year backwards starting from December, which is the most single sensitive screening item for delirium? And really important, a history, is this new? And this is where it's really important to know what people's cognitive function was like preoperatively so that we know whether there's been a change. Really, anyone who a family member is saying they're just not themselves after an operation in that first 7 days really has delirium until proven otherwise. So quite a simple screen, only takes a couple of minutes. It's been well validated in medical and emergency populations, including patients with pre-existing dementia, through work through Billelia McClellick, and very recently a publication for use in the post-anaesthetic care unit in that first sort of few hours after operation, with quite a high sensitivity and specificity for delirium. So a simple tool that perhaps we could be considering starting in that early post-operative course. The best tools for continuing to monitor for new delirium after that time are still contentious, I'd have to say, but there are a number of potential tools that you can be using. So I'm going to return to things outside of the surgical insult that might be relevant. And so we talked about the surgical insult, but really thinking about what's happening in theatre and really thinking about what happens on the ward afterwards are also really important considerations and have been an area for quite a lot of research. And this is a little bit of a busy slide, but it's a very nice review by Tamara Fong, published in Lancet Neurology in 2015. And this really is partly talking about the complexity of how much of this delirium is exacerbation of people who already have underlying cognitive impairment or dementia, which is really down under the line. Is it these inflammatory factors that are really taking those preclinical changes into a condition where you're seeing them? And how much is really de novo neurotoxicity that's related to the events happening around surgery, so hypoxia and tissue damage and potentially direct neurotoxicity of anaesthesia. So I'm going to talk a little bit about some of the evidence for this. So it would be, we know that that volatile anaesthetics, like other drugs that cross the blood-brain barrier, are potentially neurotoxic and can cause damage to brains. So trying to minimise the dose of anaesthesia or trying to avoid general anaesthesia might be logical ways of approaching reducing post-operative delirium. But in fact, there's very little evidence. There have been several trials and none of them have been conclusive about regional anaesthesia reducing the risk of delirium compared to general anaesthesia, which is really interesting. And this is a very recent paper that is a large observational cohort study that used a cohort study where there was already serial cognitive measures and looked at patients who did and didn't have interim surgery with regional or general anaesthesia. So observational study, hypothesis generating, but really they showed that the amount of cognitive decline that patients experienced was greater in people who had operations but didn't differ significantly between regional and general anaesthesia. And direct trials have also not shown significant differences between regional and general anaesthesia, although there's a lot of argument that that's because those patients still received sedative agents as well. So the jury is still a little out, but there's not clear evidence about regional versus general anaesthesia at this point. There is disparate evidence. There's two large trials of trying to use EEG monitoring to monitor depth of anaesthesia, in the thought that we may just be using too much anaesthetic agent, particularly in vulnerable older patients where the minimum alveolar concentration for a given dose of anaesthetic is higher, and so that we should be modifying the dose and doing that through some sophisticated EEG algorithms. The CODA trial, which is on the left, did show a reduction in post-operative delirium. The more recent Engages study, both large, well-designed randomised trials, did not show any difference in post-operative delirium, so expert recommendations are still that we don't have strong enough evidence for intraoperative EEG monitoring, although EEG companies seem to be telling us differently. There is probably consensus that thinking about the age of your patient in terms of delivery of volatile anaesthetic agents is crucial, and thinking about age adjusting MAC is important. Very briefly, there's a large observational study recently published in The Lancet, the Neurovision study, that did serial MRIs in patients who didn't have cognitive impairment and didn't have a post-operative stroke, and showed that 7% of patients having anaesthesia with no evidence of stroke actually have a new stroke on MRI, and that this is a significant predictor both of delirium, post-operative cognitive dysfunction. This has only been published in the last couple of months, and I think it's really going to increase interest about intraoperative cerebral perfusion monitoring. But I'm not going to talk more about that at the moment. So really the implications of that evidence for practice is that really thinking about cognitive status before operation so that we can recognise changes post-operation is important. That we still are not quite sure what to do with agents and monitoring in theatre to prevent delirium, unfortunately, but probably minimising MAC is important. So that's the kind of intraoperative things. Now, my real space is what we do in the post-operative space around delirium prevention, and there is very strong evidence about what we should do here. And I mentioned some of this. So drug therapy first. So there's a review published last month about use of antipsychotic drugs to try to prevent delirium, and there are 3 very small trials that suggest using second-generation antipsychotics might reduce delirium. But there are some methodological problems with each of these trials, and again, expert consensus is still that we should be not using antipsychotic drugs to try to prevent delirium, and we certainly shouldn't be using them to treat, which I'm sure Gideon's going to talk about. A fascinating trial out of post-cardiac surgery, the Dexaset study, again published just this year. This was looking at whether using different sedating agents in the post-operative period might influence the cause of post-operative delirium, and it was a 2x2 factorial design, so they were comparing dexmedetomidine and propofol in one arm, and they were also comparing Panadol or no Panadol, so intravenous 8th-hourly dose of Panadol. There was no difference between the 2 different agents in either of the arms. The 2 different sedating agents didn't matter which you used, but it really, really mattered whether you got given Panadol post-surgery. So Small trial, needs to be replicated, only 60 patients, but a very, very strong signal that post-operative regular Panadol made a huge difference in delirium rates. So this is really one of the new players on the block, and I think very important. I think pain is a really, really important factor in delirium prevention. And of course, opiates also create delirium, and so it's been quite difficult to unpick analgesia versus opiate use. But what I'm really interested in is non-pharmacological delirium prevention programs. So this is organised, structured programs that deliver critical fundamental cares to patients in that post-operative ward setting. And there is strong evidence from a number of well-designed trials, both in surgical and in medical patients, that these make a 30% reduction in delirium. Now, this is very messy. This is an analysis of the different components of these multi-component interventions. Unpacking multi-component interventions is tricky, but the fundamental components across the board are early and regular mobility, adequate nutrition and hydration, meaningful cognitive activities beyond reorientation, and careful use of good medications to treat pain and rationalisation of neuroactive medications. And these are the fundamentals to good care for older patients, but they are fundamental to delirium prevention. And the challenge is how we actually deliver that in a structured, organised way. And there are a number of examples for this. There's some good evidence for a modified hospital elder life program in abdominal surgery patients from Cheryl Chen in Taiwan. And we have published earlier this year a paper that I spoke about yesterday around using a program that's called Eat, Walk, Engage, which tries to put these fundamental processes into everyday care by working really closely with a multidisciplinary team on the ward, identifying barriers and enablers and gradually moving through that process. And we're able to show a significant reduction in delirium and functional decline through that process. It costs money. You have to invest in a facilitator and you have to invest in the process change, but there is good evidence from these other multi-component programs. So these are cost-effectiveness plans, and they show that not only do you save money, but you also improve outcomes. So if you're an intervention, you want to be in the bottom right-hand corner of a cost-effectiveness plan. And it's very clear, both in medical and surgical populations, that delirium prevention is cost-effective. And in Queensland, we actually have recently been funded to implement a delirium prevention program in 20 wards across 12 hospitals because of this strong evidence. So the take-homes so far are that delirium is common, that it's bad, it's got significant short-term and long-term implications, so we need to be including it in our consent processes and we need to be noticing it much more than we were. That cognitive impairment is a major risk, so we need to be screening for it. That we often don't notice it, and so we need to be using some validated tools to do that. Pain relief seems to be important, and the best way to administer that needs to be thought about carefully, and there'll be more trials in that space, and we're still not quite sure what to do in the anaesthetic space. But we do need to be investing in the post-operative space in organised delirium prevention programs that target at least our most vulnerable patients. So I'm going to hand over to Gideon, and in the meantime, save the date. If you want to know more about delirium, the Australian Delirium Association meeting is on 2nd to 4th of September in sunny Brisbane. Again, if you're enjoying it now. That the registrations for that will be opening very shortly at the end of the month. I'm going to hand over to Gideon.
Top Bed Talk.
Nick Mudge here. Have you got yourself onto edpom.org yet? If not, you might not be aware, EdPom Chicago tickets are free for a limited period only. Go now to edpom.org. Evidence-based perioperative medicine. edpom.org.